So the major usefulness of blood activation markers is that they are very useful surrogate endpoints to clinical events in all validation studies for new anticoagulant and antithrombotic drugs. They can allow monitoring therapy efficacy, and they can also allow establishing risk assessments for some disease, either for prognosis, for risk of recurrence, and I will come back to this with microparticles, or early diagnosis of a disease stage in the clinically silent period. They can be also of diagnostic help for some clinical diagnosis by their negative or positive predictive value. Another major issue for blood markers is the laboratory practice. Technology use must fit the expected clinical application. We can need the result very rapidly, or we can wait for several hours. So the technology used must fit this expected application. And sometimes rapid assay, semi-quantitatives are the best ones to be used. The pre-analytical variables concerning blood sampling and plasma preparation must be fully controlled and well established, and we need to have quality controls for validating the assay and having reliable results. The definition of the clutter value must be clear, and biological marker, what is important, is never a diagnosis by itself, but it must always be analyzed respectively to the patient context. Now I will extend on two different new blood activation markers, mainly on microparticles and on fibrinolysis. You know that microparticles can be released in blood from many different blood cells, including endothelium, platelets, erythrocytes, or white blood cells. And these cells can receive stimuli from a hypercoagulability stage, inflammation, infection, or malignancy. And according to the trigger, then we can have release of some microparticles of different cells. And according to the disease stage, some cells will be more stimulated than the others. This is summarized on this slide, where there is the pathological trigger. This represents endothelium, and you can see that the stimuli can trigger different blood cells which release these microparticles, which size is very small. They can go from 0.1 micron to less. And you know that the very, very low microparticles are exosomes, but we will focus here only on microparticles with size of 100 nanometers to about 10 nanometers, which contain phospholipid surface and also some surface proteins. So microparticles are generated when during cell activation, cell disruption, or apoptosis, when there is the breakage of membrane asymmetry, and some parts of the phospholipids membrane can be released as microparticles. And these microparticles can carry some proteins which are already present on the cell surface. The characteristics of these microparticles, according to the cell origin, are for platelets, they can contribute to activation of coagulation, and when there is activation of coagulation, platelets release microparticles which contain a procoagulant phospholipid surface, but also tissue factor. Tissue factor which can be synthesized in platelets, and this can be one of the major initiators of blood coagulation in vivo. And probably, if I make a link with Professor Mann's presentation, which the additional supply of tissue factor and phospholipids, which can help amplification of coagulation reactions. Autoimmune disease, TTP, and activation of coagulation also can stimulate endocellular cells. In infection and inflammation, we have a major contribution of monocytes to generate microparticles, and in inflammation also on leukocytes. And in diabetes, many microparticles from lymphocytes can be present. These microparticles are active products which can express procoagulant activity because they expose phosphatidylserine, a procoagulant phospholipid surface, and they can also expose some proteins such as a tissue factor. And they can contribute to upregulation of tissue factor present in plasma and in blood. They can contribute to generate some platelet leukocyte aggregates. And they enhance monocyte endothelium adhesiveness. So they have many roles in worsening progression of disease. And finally, they can also have pro-inflammatory activity. Microparticles are a very long half-life, which makes their usefulness for diagnosis, for prognosis, or for monitoring therapy efficacy. The half-life is of about 6 days. They bind to annexin 5, they are released from many blood cells, and they expose CDs. I mentioned TF, but we can also find on some MPs TM or GP2B3A or other proteins. So finally, microparticles are not only the consequence of a disease stage, but they contribute to worsen this disease stage if they are present at a certain activity. So in some clinical contexts, microparticles can be useful. For example, in hemophilia. In hemophilia, we have increased levels of microparticles, but they are beneficial because they contribute to improve hemostasis in these patients. But when they are present at an excess level in normal individuals, they are pathogenic. For the different reasons that I explained, and this is why these microparticles are consequence but also cause of disease. And recently microparticles have been demonstrated to impair function of normal endothelium by improving NO metabolism. They decrease NO and its relaxing effect, and then they impair function of normal endothelium. The pathological variations of microparticles are documented because there are increasing numbers of papers published on these clinical applications. They are elevated in MI 2 to 10-fold the normal range, which is below 10 nanomoles. They are elevated in cancer, and some recent studies, mainly in Japan, propose these microparticles being predictor of cancer metastasis, especially they were studied in gastric cancer. They can predict vascular complications in diabetes, especially in type 1 diabetes, where microparticles are originate from platelets and endothelium, whilst in type 2 they are originate from monocytes and lymphocytes. They are elevated in hemophilia, but they can be beneficial. They are elevated during Novo-7 therapy, and they correlate with severity of hypertension. And what is interesting, they respond to therapy efficacy. And sometimes very simple therapies have been proven to be useful in reducing the concentration of microparticles. For example, vitamin C in coronary disease contributes to decrease microparticle concentration, and then it can be useful adjuvant therapy.